Pleasure to introduce our next symposium. I will be co-moderating with Dr. Dobbs. We put together a symposium looking at the latest and greatest in terms of controversies, topics, as far as cervical spine technology, and questions that we often get with these topics. We put together a great slew of speakers and topics. I'd like to point out that there is one additional talk in this session from Samuel Cho, looking at different materials for the use of interbody cages as well. Our next speaker is Dr. Ahilan Sivaganesan, talking about interbody cage materials with PEEK and PEC, which are both plastics.
Good morning, everyone. My name is Ahilan Sivaganesan. I go by Siva. I'm a neurosurgery faculty at Jefferson. This was actually Greg Schroeder's talk, but he couldn't make it today, so I'll be presenting his talk. Some disclosures. I don't know the specifics, but so, background. Obviously, we all know here that anterior cervical surgery is a very successful operation at both 2 years and 5 years with long-term outcomes. We see, very satisfactory satisfaction rates, both for radiculopathy, myelopathy, both for ACDF and for arthroplasty. One of the sort of open questions that gets debated, every year is, what is the true prevalence and impact of pseudoarthrosis? One of the problems, of course, is that there's a lot of heterogeneity in the way that pseudoarthrosis is reported in the literature. And obviously, Dr. Rue and many of the luminaries here have worked to standardize this, but when you look at different studies, not all studies use the same modalities to measure pseudoarthrosis. So here's an example of one study where they saw a revision rate at 2 years of about 2% in a single center study compared to an average of about 9% in some of the control arms from IDE studies. Another paper where they looked at almost 600 ACDFs and 1,200 ACDFs levels, and they found a pseudoarthrosis rate of 36%, and however only about 5% required a revision. Interesting point here is that when they compared patients that had a pseudoarthrosis but not requiring a revision to those that had a solid fusion, the outcomes were not much different. But when you looked at patients that actually required a revision for a pseudoarthrosis and compared those to those patients who had a solid fusion, there was a significant difference in those outcomes. So the question then becomes is interbody cage design part of the solution to this problem? But because of the heterogeneity that I mentioned earlier, it's really hard to make sense of some of these comparative studies. So here's a systematic review that just came out recently that showed no difference between PEEK and titanium in terms of fusion rates in either standalone context or a cage and plate construct. So, the point here being is that with so much heterogeneity, if you have garbage in, are we getting garbage out, and can we really make sense of some of these findings? Here's a study that looked at comparing PEEK and structural allograft, and you can see here 2-level fusions, 7% versus 8%, and then 3 levels, 10% versus 11%. Here's another paper from this year, 33 patients, 3-level ACDF, 32 out of the 33 had a solid fusion at all levels based off of flexion extension, and 2 patients had graft subsidence. So porous PEEK is worth mentioning here, of course. An important point to make is that even though we call it porous PEEK, it's not porous all the way through. It's really roughed edges with a few millimeters on both sides. And of course, PEEK, one of the main advantages is that the modulus is similar to bone, more so than metal, and it's radiolucent. And we know that the incorporation of this porosity into PEEK has been associated with cytocompatibility and as well, cellular proliferation and cell-mediated mineralization significantly greater on a porous PEEK surface as compared to a smooth PEEK surface. We also know that pre-osteoblastic cells on a porous PEEK surface produce significantly more calcium, osteocalcin, and VEGF than smooth PEEK. And it also leads to increased alkaline phosphatase activity, which also underscores the effect of porosity on osteodifferentiation. So there's also new HA-coated porous PEEK, which just received FDA clearance. This is very new, and so data will be upcoming. But the other big topic, of course, is PEC, which is less hydrophobic than PEEK. It's 3D printed and allows for complete porosity as well as compared to the description earlier for porous PEEK. So here's a basic science study comparing PEEK and PEC. There's more micropores, higher hydrophilic groups found on the porous PEC compared to PEEK, more bone-like apatite crystals deposited on PEC compared to PEEK. And some analyses have also shown that the newly formed bone in PEC is nearly more than double that in PEEK. So here's an in vivo study that looked at 3 different materials: PEEK, titanium-coated PEEK, and then 3D printed PEC. And they tested this on 8 ovine specimens. And what they found is that the PEC implants demonstrated bone ingrowth, no radiographic interference, no fibrotic tissue membrane formation, and significantly increased bone apposition over time and higher push-out strength as compared to standard PEEK. And so this PEC implant shows bone growth characteristics that are comparable to titanium-coated PEEK, but with implant integrity and the favorable radiographic properties. So there's some upcoming data coming out with 50 patients that Dr. Schroeder's group have looked at with porous PEC cages and at CT scans at 1-year follow-up and an 86% fusion rate at 1 year. So, in summary, for porous PEC, you can make the argument that it has many of the benefits of PEEK, but perhaps improved fusion outcomes. But of course, this is all based on basic science data at this point. But as mentioned earlier, with the heterogeneity and pseudoarthrosis reporting mechanisms, it may be hard to really show a definitive superiority. A brief mention about porous titanium. This has been around for quite a while. And the thought, of course, is that the increased porosity and the changes in the cage geometry that you can design could help affect and reduce subsidence rates. And so, porous titanium, when you really look at it, you can see that the properties of non-porous titanium have a much higher modulus than that of cortical bone. But as you increase the pore size and density, that gap starts to shrink. And specifically, when you get to about high density, 60 to 80% porosity, that gap between the modulus of 1 to 3 GPa for porous titanium starts to approach that of trabecular bone. So in conclusion, we all know that an ACDF is a wonderful procedure. There's still some uncertainty around the true pseudoarthrosis rates. And while the procedure has really been mastered by the field, it may be that these kinds of improvements in implant technology can further decrease pseudoarthrosis rates. Thank you very much.
A question for Dr. Sivaganesan. Sam presented some studies on how we evaluate fusion, whether it's flexion extension versus CT scans, and a lot of this is borne out in the fact that PEEK cages don't integrate with the bone, so you may see bone go through the cage on a CT scan, but it doesn't really move on flexion extension. So my question to you is, how do you evaluate somebody who you think has a pseudoarthrosis, and will it matter if somebody has a PEEK versus titanium versus bone cage?
That's a great question. I personally, I'm only 1 year in practice, but I used, Dr. Rue's methodology that was discussed on this seminar. If I have a clinical suspicion of pseudoarthrosis based on the patient's presentation, and then it's confirmed by flexion extension views using that specific methodology with zooming in and doing the interspinous measurements, that's when I tell myself, okay, this is now a clinically significant pseudoarthrosis, which I'm assuming most people in the audience do something similar. In terms of your question about how you then interpret that in the context of different cage materials. My experience is pretty limited. I use titanium almost exclusively, and that's just based on the training that I had. And so I may not be able to speak fully intelligently on how to differentiate the decision making based on if it was a PEEK or PEC versus titanium. So I may not be the best person to answer that aspect of the question.
So let me then ask you then, if you have 1.5 millimeters of motion and somebody is a year out and they have pain, are you going to operate on that patient and call it a pseudoarthrosis?
I might ask Jim Harrop what he thinks first. But realistically, no. And I think I think because the level of suspicion required to do a revision operation is not the same as the bar that exists to call something a pseudoarthrosis, like internally amongst each other. And I think that gap is why you see the differences. So that's my honest answer on that. Yeah.
Great. I want to thank all the speakers for a great session. Thank you.